This module will be covering 3 different procedures that are used for various pathologies in the shoulder. We'll be discussing hemiarthroplasty, total shoulder arthroplasty, and reverse total shoulder arthroplasty. The purpose of this module is to have you understand why one of these procedures would be used. After a patient has this procedure, what are some precautions that you and they must follow, to give you the information so that you can educate a patient on what actually happened, and for you to understand the altered mechanics that are now in the shoulder region as a result of these procedures, and then to understand the different phases of rehabilitation following either a hemiarthroplasty, a total shoulder, or a reverse shoulder arthroplasty. To give you a little bit of background, the first shoulder was implanted back in 1893 by a French surgeon, and he inserted a platinum cylinder with a rubber head in a 37-year-old patient who had tuberculosis of the shoulder. These procedures were then used in the 1950s in this country to treat comminuted fractures of the head of the humerus, and this was led by Dr. Charles Neer. 20 years later, Dr. Neer added the glenoid component and described the total shoulder replacement for the treatment of osteoarthritis. So in this patient population, the options were hemiarthroplasty, total shoulder arthroplasty, and reverse total shoulder arthroplasty. So what we're looking at here are pictures of those various procedures. On the left, what you can see is that the humeral head was resurfaced with an implant. The glenoid surface was intact and was not replaced, and that is known as a hemiarthroplasty. The upper middle picture, you once again see that the humeral head was resurfaced, but they also inserted a stem down into the shaft of the humerus. But once again, the glenoid is intact and was not replaced, so that is a hemiarthroplasty. The bottom middle picture, what you're looking at is once again the humeral head was resurfaced and there was a stem placed down in the shaft of the humerus, and in this picture we see that the glenoid was replaced with a plastic socket, and that is known as a total shoulder joint replacement because both sides of the glenohumeral joint were replaced. And on the bottom right you can see the picture of an x-ray of a reverse total shoulder replacement. So both sides of the glenohumeral joint were replaced, but here you can see the glenoid side now has become the convex joint surface and the humeral side has become the concave joint surface. Now this procedure has had large numbers of patients who have undergone total shoulders and hemiarthroplasties. Back in 2000 there were about 14,000. 8 years later that number rose to about 47,000. In 2003, the FDA approved reverse total shoulders in this country. They were first being done over in Europe years prior, but was not approved in this country until 2003. Today, about 53,000 people in the United States have shoulder replacement surgery each year, and according to the Agency for Healthcare Research and Quality, this compares to more than 900,000 Americans a year who have knee and hip replacement surgery. So this, in 2011, this was just a study that looked at that there were 66,000 people who had one of these 3 procedures. 32% roughly had reverse total shoulders, 44% had a total shoulder arthroplasty, and 23% had hemiarthroplasties. Now what we're looking at here is what are the typical diagnoses that our patients would be coming into who undergo these procedures. So the indicating diagnosis for a reverse total shoulder, typically the primary diagnosis is osteoarthritis, followed by a rotator cuff tear. So most of these patients do not have an intact rotator cuff, and they may have undergone a primary total shoulder replacement, but because they didn't have a rotator cuff, the total shoulder replacement failed and they ended up undergoing a reverse total shoulder arthroplasty. When looking at just the total shoulder arthroplasty, the primary diagnosis was osteoarthritis. And for hemiarthroplasty, once again, it's osteoarthritis, but followed very close behind proximal humeral fractures. So the average length of stay for these procedures is roughly 2.5 days, with the hemiarthroplasty length of stay being greater than the reverse and being greater than the total shoulder arthroplasty. The mortality rates, roughly symmetrical in the reverse and the hemi, with the total shoulders being the smallest. The reverse shoulder arthroplasty patients were more likely to be performed in the elderly patients compared with those who underwent a total shoulder or a hemiarthroplasty. Reverse shoulder arthroplasty patients have more medical comorbidities and higher hospital costs. So switching gears for a little bit to look at fractures. The most common fracture type in individuals older than 65 years, first is the distal radius. This occurs when they fall on an outstretched hand. Second, proximal femur fractures. And third are proximal humeral fractures. So Dr. Charles Neer developed the classification of proximal humeral fractures in 1970. And this classification system was based on two components: the number of fracture parts and whether or not those parts were displaced. So Neer's system divides the proximal humerus into 4 parts and really focuses on the displacement of those parts as being the important or the significant item in terms of classification. So the 4 parts are the humeral head, the greater tuberosity, the lesser tuberosity, and the humeral shaft. Displacement is defined as a piece that is angled greater than 45 degrees, or that piece is displaced by more than 1 centimeter. So his classification system is visualized here. So in a 1-part fracture, there's one piece that is fractured, but none of them, or that one piece is not displaced, meaning it's not moved more than 1 centimeter or angled more than 45 degrees. Now these kinds of fractures, a 1-part fracture, account to roughly 80% of all proximal humeral fractures, and those individuals are most commonly treated conservatively. A 2-part fracture involves 2 pieces, and 1 part is displaced as per the definition, and that one piece could be the greater tuberosity, the lesser tuberosity, or certainly a segment at the level of the anatomical or surgical neck. Now these 2-part fractures account for approximately 20% of proximal humeral fractures. A 3-part fracture, as you can imagine, is 3 pieces, and 2 of them are displaced, and these account for approximately 5% of fractures. And in the last case, the 4-part fracture, all 4 segments, there's 4 segments and all 4 are displaced. And thankfully, these are uncommon. They only account for less than 1% of proximal humeral fractures, but these individuals usually require operative management because they have poor non-operative results. So we're going to focus a little bit of time right now on hemiarthroplasty of the shoulder. So who are the individuals that would have a hemiarthroplasty? This is in a situation where the glenoid is intact. They may have fractured their proximal humerus, but the glenoid is okay. This may also be in a young active patient with OA, where they may be post-traumatic, where they may have a massive rotator cuff tear. Now, if an individual has the glenohumeral joint where the glenoid is degenerated, but they are unable to place a glenoid component, then they may just do a hemiarthroplasty. This could be an individual that has risk of glenoid wear or where loosening of that prosthesis is high. So on the left picture you see a multiple piece fracture of the humeral head that is displaced, and on the right you can see that the humeral head was resurfaced and there's a stem that was placed down within the shaft of the humerus. To give you an idea of this surgical procedure, they usually take a Deltopectoral approach. The coracoacromial ligament, if present, is preserved. They incise the subscapularis, dislocate the humeral head and cut it off. Then they drill a canal into the shaft of the humerus, and that prosthesis is then placed down inside. and the humeral head is retroverted approximately 30 to 35 degrees. The prosthesis is cemented, and then any tendons that were excised are now repaired to the bone with sutures. The subscap is often moved to the superior aspect of the greater tuberosity. A suction is then placed, and then the deltopectoral interval is then closed. Typically, these patients are placed in a sling for approximately 3 weeks. The only time that they would take it off is if they are bathing or they're performing some exercises. For these patients, we initially will be working on passive range of motion, and here are our goals: 30 degrees of external rotation and forward elevation in the supine position to approximately 130 degrees. And this is our goal to obtain 8 to 12 weeks post-surgery. We can do pendulum exercises to try to get some general motion in the shoulder. We perform external rotation or active assistive external rotation with a stick. At approximately 8 to 12 weeks, or 2 to 3 months following the hemiarthroplasty, we begin active assistive and isometrics below horizontal, and once they demonstrate good control, meaning not seeing movement dysfunction or compensation, we begin active exercise to tolerance as initiated. The post-op period for this patient is usually approximately 3 months. Now, looking at the total shoulder arthroplasty, just to give you an idea of the lifespan of a total shoulder replacement, in a study by Torquia et al., 98% of patients, the joint survived 5 years, 93% it lasted 10 years, and 87% it lasted 15 years. So it has good long-term outcomes. Glenoid radiolucent lines and loosening are associated with poor results, and with recurrent pain and progressive loss of active elevation are also associated with poor results. So what are some prognostic factors for patients who are going to undergo a total shoulder replacement? So for patients with a rotator cuff, most with primary osteoarthritis do have an intact cuff, and this was well documented. Neer reported that less than 10% had a tear, but usually it was quite small. The long head of the biceps tendon has been found to be abnormal in 30% of patients, and that tended to have a decreased outcome. Fatty infiltrate of the muscle, and we usually see fatty infiltrate of especially the rotator cuff muscle if it's been torn for some period of time, and we tend to see some recoiling of that rotator cuff muscle. So the degree of this fatty infiltrate occurring within the rotator cuff muscles will definitely impact the functional outcome of a patient undergoing TSR. In addition, the deformation of the glenoid in osteoarthritic patients has an effect on surgical outcome. So what are some contraindications for a patient to undergo a total shoulder? Certainly if they have an active infection, if they have severe rotator cuff or deltoid pathology, usually these individuals, the total shoulder will fail and they'll end up having to undergo a revision. In addition, if they have severe neurological conditions, especially any kind of upper motor neuron lesion, it's usually contraindicated for that patient to have a total shoulder. Things that will play a role in rehabilitation is the component which was used, the bone and soft tissue quality, meaning if there's the soft tissue quality, is there a lot of fatty infiltrate, is there recoiling of any of those muscles, and certainly the bone itself. How is the bone stock for the implants to be placed in? And certainly the goals and needs for each patient. What are some of the anesthetic options for a patient undergoing a total shoulder? Typically, we'll see an interscalene regional block. Certainly the patient is sedated, but the anesthetic option is to have a block, and they certainly can undergo this procedure under general anesthesia. So what happens when you have a total shoulder? Once again, the deltopectoral region is incised, the soft tissue is retracted, meaning the deltoid and the pec muscle are separated. The coracoacromial ligament may be released. They look at how much external rotation the patient has, because if they have severe limitations, they may have to do a loosening procedure of the subscap. They dislocate the shoulder joint. They do an osteotomy of the humeral head, meaning they cut off the humeral head and any osteophytes are removed. The glenoid is exposed, and they determine what kind of glenoid plastic implant would be appropriate for this patient, and they then place that glenoid implant first. The humeral head stem size is then determined. A canal is then drilled into the shaft of the humerus, and the implant is inserted. Again, it is cemented inside the humerus. Then any muscles that were retracted or released are then repaired, and any lengthening is performed, especially in the subscap, if external rotation was markedly reduced. The wound is then closed, and the person is placed in a shoulder immobilizer. So here you can see a post-op film on a patient who had a total shoulder replacement. So you can see the humeral head resurfaced and the shaft, or I should say the stem down in the shaft of the humerus. Now on the glenoid side, you don't see much of a prosthesis because it is plastic, and here is the actual fixation of the glenoid component onto that glenoid. So here, this is a protocol that was published by Cahill and Kavanaugh out of HSS back in 2014 for rehab following total shoulder arthroplasty. Now, there are various protocols out there. This is just a general guideline that may be helpful for you to follow when treating a patient postoperatively. But early on, the first month, really you're trying to decrease pain, decrease edema, and progressively move or increase their range of motion. What we want to avoid is any unnecessary lifting beyond their normal ADLs, and certainly you want to go under the guidance of your MD in terms of how much motion or what motions you should avoid, and that will really quite often be determined about the bone stock of the patient and how the procedure itself went. But the patient is in a sling for light ADLs, they're in a sling except for when they do light ADLs or they're doing their exercises. So they'll begin with pendulums, do passive range of motion, progress to active assistive range of motion where they typically will be using a wand or a cane or a stick, but they want to maintain motion or elevation in the plane of the scapula. We certainly at this point can do a lot of scapular stabilization, making sure it's mobile, but start working on the scapula during this early phase when the glenohumeral joint is kind of restricted. In time, we can certainly have them use the elbow, wrist, and hand, but we don't want excessive lifting with those joints. In order to move on to the second phase, we want to make sure that pain is controlled and that they've achieved the following range of motion: elevation to 120, external rotation to 30. We want them to be independent with light ADLs and certainly the home exercise program that we've given them. In the second and third month, we are progressing everything that we did from phase 1 and moving on to doing more advanced forward flexion, doing some active range of motion. It's beginning to work on humeral head control, so you're looking at rotator cuff activities, but we're really beginning with isometric exercise in what we call a neutral position. External rotation, we do not go beyond 30 degrees, and internal rotation is only to neutral at least until week 6, especially if they've had any kind of subscapularis activity or work done on their subscap during the procedure. We can certainly progress scapula stabilizing exercises as needed. In order to move on to the next phase, the patient shouldn't really have any pain with ADLs, and our range of motion goals to move on is that they've achieved 150 degrees of elevation in the scapular plane and 45 degrees of external rotation. Moving on to months 3 and 4, continuing with what we were doing before, but we're avoiding any activities that cause some discomfort, and we're wanting to make sure that we don't see any scapula hiking or any poor dysfunctional movement. But we're progressing strengthening exercises still with isometrics, doing scapula stabilization. We can do resistive exercises for the scapula and the elbow, and we're keeping forward flexion in the scapular plane. In order to move on, again, no pain with advanced ADLs. You can see the range of motion goals at this point. We want elevation to 160 degrees and external rotation to 60. We want them to be able to internally rotate to T12 so they can reach behind their back and reach up to the level of T12. And we really want to see good scapulohumeral rhythm in the motion that they've got. Now we're moving on to 4, 5, and almost into 6 months. So here we want to really be maximizing range of motion. We want to make sure that there's functional muscle strength throughout the entire upper extremity, that we see good scapulohumeral rhythm, especially above 90 degrees of elevation. We want to still encourage our patients to avoid any activities that cause pain, and they still should be avoiding lifting heavy objects. In order for our patients to be discharged from therapy, and quite often that discharge will be dependent on insurance, but we want them to have maximal range of motion. They should be independent with ADLs. They should have good scapulohumeral rhythm, especially overhead activities beyond 100 degrees of elevation, and they have good functional muscle strength in the entire upper extremity. So this study was looking at the return of subscap strength after shoulder arthroplasty, because that is incised, and quite often patients have some limitations following this procedure. So this study looked at 64 patients who underwent a unilateral total shoulder, and they compared the subscap strength between the surgical and the non-surgical side at baseline and at follow-up. And while the involved side had a significant improvement from baseline at 2 years follow-up, the subscapularis strength only returned to normal, meaning symmetrical with the other side, in a minority of patients. So, should you have a hemiarthroplasty or a total shoulder arthroplasty? In general, for the treatment of osteoarthritis, the total shoulder typically gives superior results to the hemiarthroplasty in studies that looked at midterm follow-up from baseline. Edwards et al. Looked at patients in osteoarthritis. The total shoulder replacement was superior in terms of relieving pain, active range of motion, functional scores, and patient satisfaction. In terms of complication rates, this study showed that there really was no significant difference between the two. Gartzman et al. Found that patients who had a total shoulder replacement had better relief of pain and internal rotation when compared to those with the hemiarthroplasty. So, as I mentioned, the reverse or inverse total shoulder arthroplasty, or otherwise known as RSA, it was first performed in Europe about 20 years ago, but it was not approved by the FDA to be performed in this country until about 2004. So who has a reverse total shoulder? Usually patients with rheumatoid arthritis, somebody who had a failed total shoulder arthroplasty. If they had an open reduction internal fixation of a proximal humeral fracture that was associated with rotator cuff deficiency, it's usually used as a reconstruction after a tumor resection, or if they've had complex fractures of the proximal humerus, a very certainly hard procedure. So typically what happens when there's a massive tear of the rotator cuff, we now have instability of the humeral head. What occurs is that there's leakage of the synovial fluid, and we get this destruction of the glenohumeral joint articular cartilage, because that rotator cuff, which will hold that humeral head in place and prevent superior migration, it's not working. So we get massive destruction of the joint, we see osteoporosis, and we get this collapse of the humeral head. It just gets crushed underneath the subacromial space. So the glenohumeral joint biomechanics become altered because we get this superior migration of the humeral head, and it articulates with the undersurface of the acromion. We get destruction of the coracoacromial ligament as well as the AC joint. So here you can see that the RSA is a reverse ball and socket prosthesis. So you have the convex glenoid moving on the concave humeral head. So it's designed to restore overhead function in the presence of an irreparable rotator cuff deficiency. So you will really see this procedure being done in patients who have osteoarthritis, but they have major rotator cuff arthropathy. Okay, so it uses, and this procedure uses an intact deltoid muscle, and the stability of this joint is provided more so from the design of the prosthesis. In this procedure, the center of rotation of the shoulder joint is moved slightly medial and inferior. So this allows an increased deltoid moment arm, and it increases the line of pull and action of the deltoid. So this deltoid now compensates for a deficient rotator cuff. It becomes the primary elevator of the shoulder joint. So patients are able to raise their arms overhead, so they can have full functional motion, but just that most of the activity now is as a result of deltoid activity. So this was a study that looked at outcomes for patients who underwent a reverse total shoulder arthroplasty secondary to rotator arthropathy or deficiency. So they found that active shoulder rotation was not really shown to improve after a reverse total shoulder, and those who had deficient teres minor had really marked limited external rotation following this procedure. Those who had an intact teres minor had an average of 15 degrees of active rotation. Now, since this study was published, there's been some modifications to the procedure so that these numbers are actually much more functional. So this picture here, you're just seeing how the humeral head is migrating superiorly, and we're starting to see destruction of this joint. And now this joint has been replaced with a reverse total shoulder, and these are some postoperative films where the replacement, the prosthesis is well aligned. Now, how do we rehab these patients? So the rehab is definitely going to be different than somebody who had a total shoulder replacement. I mean, the mechanics are different. Somebody who had a reverse total shoulder, most times their rotator cuff is either absent or minimally functional. So they have different precautions. So you really need to know the surgical approach before treating a patient. So if you just know they had a shoulder arthroplasty, you want to know whether or not it was a total or a reverse. So there are some options in terms of the approach to this procedure, but typically we'll see a deltopectoral approach or a superior approach. And if somebody has a superior approach, so it's important for you to know, that early deltoid activity in this individual is contraindicated because they're going in from the deltoid, so it needs time to repair. So what you need to know before you're working with a patient, you need to know what was their shoulder like before the surgery. What kind of implant was used? Was it cemented or not? How was the quality of bone that the implant was placed in? How was the integrity of the remaining rotator cuff? Was a lot of fatty infiltrate? Was there a massive tear? Did they end up repairing that rotator cuff along with doing the shoulder arthroplasty? And how, when everything was all said and done, how stable did the prosthesis seem? So Boudreau in 2007 was looking at some postoperative rehabilitation concepts. He found that there was a higher risk of dislocation for patients who had a reverse shoulder arthroplasty, and this will occur when the person is in internal rotation, adduction, and extension, as if they were reaching behind their back to put something in a pocket. So there was a higher risk of dislocation in patients with the reverse than the total shoulder. So those motions that I've just indicated would be avoided for no less than the first 3 months. So a reverse total shoulder, you avoid internal rotation, adduction, and extension. It's those combined motions. And with a total shoulder arthroplasty, you're avoiding the positions of abduction and external rotation, kind of like that throwing position. Now, the deltoid function. You need to know the approach, meaning where did they begin the surgical procedure? Was it deltopectoral? Was it a superior approach? So we need to progressively emphasize deltoid and periscapular strengthening so as to establish appropriate and functional range of motion expectations. So in terms of range of motion and functional expectations, it does depend on the status of the external rotators. Can the deltoid and the scapular muscles be strengthened? Because obviously to be able to do those, strengthen those muscles, quite often you need to position the humerus. We should be able to get at least 105 degrees of shoulder elevation in these patients. And if their patient has significant preoperative external rotation weakness, quite often the surgeon will consider doing a transfer of the latissimus dorsi muscle to try to facilitate or enhance external rotation strength. So patients who undergo a reverse total shoulder, there is 4 phases of rehabilitation, and you can see the names of them here. But really what you have to be careful of is you need to respect the healing of the structures, especially the soft tissue structures. So if they incise the muscle, if they retracted a muscle, you need to give it time to heal before we create tension across it. So this is just going through the different phases. I'm not going to read off the slide, but what you want to take from this are what are our main goals and what are the things you need to avoid. We do not want to fail this procedure, to cause failure. So in a patient who had a reverse total shoulder, you are not doing internal rotation range of motion because that increases the likelihood of them dislocating, and also the muscles that were involved that were retracted may rip off. So there's no shoulder active range of motion or lifting with the involved upper extremity during this phase. Patients who are status post reverse shoulder following a failed total shoulder are usually immobilized longer. Once you start to get into secondary surgeries or revision surgeries, the extensibility of the soft tissue is diminished. So we have to be careful and give it more time to heal. So those individuals, we usually don't do passive range of motion until 3 to 6 weeks. So if somebody just had a primary, when I say primary, I mean for the first surgical procedure on their shoulder, their first arthroplasty, if they had a reverse total shoulder, we can start with passive range of motion right away, of course avoiding internal rotation passive range of motion. But if they've had a revision surgery because their total shoulder failed, we're not going to do passive range of motion for 3 to 6 weeks. If this patient had the superior approach when they go in through the deltoid, we're going to do passive range of motion at 3 to 4 weeks, and we're not going to do any kind of deltoid activity, even isometrics, until a month out. We'll do active range of motion into flexion at 6 and isotonic deltoid activity 3 months later. So it's really, really important to know your precautions. What are things that you're going to avoid and educate your patient to avoid so that they are successful. So early on, things are limited, but they will return to pretty good functional range of motion and strength. And this is just kind of telling you the conversations that you'll be having with your patients. So they are put in an abduction type sling that places them in about 30 degrees of elevation and abduction, and they're in that for about 3 to 4 weeks. You will tell your patient that you always want to be able to see your elbow no matter what you are doing. And what we're really saying there is we don't want the arm to go into extension internal rotation behind the back, which would increase the likelihood of dislocation. We don't want them to reach across their body with this involved upper extremity. And if they had a posterior cuff, so we know the posterior cuff is the teres and the infraspinatus, if it was also repaired at the time of surgery, we're going to, the patient will most likely be in an external rotation immobilizer, and where they only allow about 15 degrees of external rotation. A lot of times in these patients, pain and swelling is a limiting factor, so cryotherapy is used quite often postoperatively, and they'll be educated on the importance of reapplying it. Patients who've had that primary reverse shoulder arthroplasty with the deltopectoral approach, again, that's just where they kind of separate the deltoid and the pectoral muscle, and then they get into the glenohumeral joint. This is just giving you some range of motion guidelines, so we know that these patients are moved a little bit sooner in terms of deltoid activity, but the range of motion is just a little bit ahead of the superior approach. And this is just indicating how you'll progress the range of motion at 3 to 6 weeks. Again, this is for somebody who had a deltopectoral approach. Phase 2 is our active range of motion and early strengthening phase. Here we're moving from passive to active assistive to active, but making sure that we see good scapulohumeral motion. We don't see excessive upper trap activity, and certainly not deltoid activity, excessive deltoid activity. We do not want them lifting anything heavier than a coffee cup, and they should not be using their involved upper extremity for body weight support. So certainly doing any kind of closed chain activities for this patient is avoided at this time. Some of the exercises you could be doing. What we do want to be careful in this population is to watch out for acromial stress fractures, because the joint is moved medially and inferiorly, and we get a lot more deltoid activity. There's increased tension on the deltoid, which now becomes the primary elevator. So there's a high amount of force that is generated at the bone muscle, and what we're talking about here is the bone, meaning the acromion, and the muscle, meaning the deltoid. So there's a lot of force at that junction. So we want to just be careful that we don't see an acromial stress fracture because of the now altered biomechanics of the glenohumeral joint. And we really want to certainly watch out for that, because it could take 3 months for that fracture to heal. Phase 3, we're moving on to moderate strengthening. You can see the activities that you can do here, but we really want to focus on normal scapulohumeral rhythm, and we're progressing strength and making sure that they maintain that rhythm throughout, and we don't see movement dysfunction. Phase 4 is the home program. If we're fortunate enough to have patients in Phase 4, we would continue to work on range of motion and strength. But at this phase, in the continued home program phase, or Phase 4, usually they're discharged from physical therapy and they're able to return to light household work and leisure activities. But really, you're going to be telling your patients that we don't want them holding more than 10 to 15 pounds with both upper extremities pretty much for the rest of their lives. I don't think I've ever really heard anyone saying a specific amount of time, but this procedure is usually done in the older population, but we don't want them lifting more than 10 to 15 pounds with both hands. This, again, it was a study by Boudreau, is giving you some reverse total shoulder arthroplasty protocols, progressing you from Phase 1, which is right after surgery from day 1 to week 6, all the way to what we just called the advanced or moderate strengthening to the home program. So Kiet et al. In 2014 looked at outcomes after shoulder replacement, comparing the reverse to the total shoulder. And this was a prospective case control study. They had 47 patients who underwent a total shoulder and 53 patients who went under the reverse. The average follow-up time was 2 years, and what they looked at were complications, outcomes using the American Shoulder and Elbow Surgeon score, visual analog scale, range of motion, and radiographs looking for any kind of loosening of the prosthesis. And this study found that there were no differences in major complications or revision surgeries from these two groups. Outcomes looking at the American Shoulder and Elbow Surgeon score as well as the visual analog score. But there was comparable range of motion in both groups, except that patients who underwent a total shoulder had greater external rotation than patients who underwent the reverse shoulder arthroplasty. And here you can see that the mean external rotation in those who had a total was 53 degrees, whereas the mean for the reverse was 38 degrees, and that was significantly different.